So now let's start with the bone marrow failure. So under this, first one will be the pure red cell aplasia. So as the name suggests, here there is going to be aplasia of the red cells. So there is going to be the erythroid precursors which are going to be affected. So what are the causes for this? Mostly it is usually caused due to some autoimmune condition in which the erythroid precursors are going to be affected by the autoimmunity. Otherwise, it can be inherited as a congenital condition also. That is going to be a diamond blackfin anemia. So diamond blackfin anemia is an example of congenital cause of pure red cell aplasia. Then as a paraneoplastic syndrome, we must have read this pure red cell aplasia under thymoma. Remember? So thymoma had two paraneoplastic syndromes. First one was this pure red cell aplasia, and the second one was myasthenia gravis. Right? So as a result of this thymoma as a PNS also, we can develop this pure red cell aplasia. Then a parvovirus B19 infection. So this infection can either affect the erythroid precursors alone or any other hematopoietic precursors also. Then other viral infections like HIV, then hepatitis viruses, especially the non-A, non-B, non-C hepatitis viruses. So and then herpes infections. So all of this. Then under neoplastic conditions, again there is another neoplastic condition which is large granular lymphocytic leukemia. So both large granular lymphocytic leukemia and thymoma, you are going to have this pure red cell aplasia. Then certain drugs like NSAIDs. So all of this can directly affect the erythroid precursors and lead to decrease in the production of RBCs. Okay. So next one will be the myelophthisic anemia. So myelophthisic anemia means it means that the bone marrow is going to be infiltrated by something else. So there is no space for the hematopoietic cells, or there is going to be the bone marrow architecture loss. So all of this is going to decrease in the hematopoietic production. So it will result in pancytopenia kind of a picture. Suppose there is going to be a bone marrow metastasis or a leukemia or a lymphoma infiltration, or there is going to be bone marrow fibrosis or metastasis. So all of this, or even a granulomatous inflammation, tubercular inflammation in the bone marrow. So all of this is going to result in myelophthisic anemia because the bone marrow architecture, the stromal cells, the hematopoietic cells are going to be lost. So bone marrow architecture is going to be lost, resulting in decrease in production, resulting in pancytopenia. Okay. Apart from that, in the peripheral blood, what will be the picture in this? If you see, in the peripheral blood, there is going to be a leukoerythroblastosis. Leukoerythroblastosis in the sense, there is going to be immature precursor cells of both the WBCs and the RBC lineage in the peripheral blood. So that is characteristic of this myelophthisic anemia also. Then, since there is going to be some fibrosis or thing, the RBCs which are coming out through it is going to have a characteristic teardrop appearance. So, teardrop RBCs along with pancytopenia. So, all these features are going to be seen in myelophthisic anemia. So, the third one will be the congenital dyserythropoietic anemia. So, as the name suggests, it is going to be a congenital cause and it is going to result in anemia, and there is going to be dyserythropoiesis. So, because of the result of this dyserythropoiesis, here there is going to be a decrease in the reticulocyte count. As such, there is going to be a maturation arrest. So the precursors are affected, and after a certain point of time, there is going to be a maturation arrest. So the mature RBCs and the reticulocytes are not going to be produced properly. So this kind of dyserythropoiesis is seen in congenital dyserythropoietic anemia. In that, we have three types of congenital dyserythropoietic anemia. So the type 1 is going to be autosomal recessive, same for type 2. Type 3 is going to be autosomal dominant. So there is you don't have to remember everything in detail about this. We will just have specific questions related to this. So in type 1 congenital dyserythropoietic anemia, on electron microscopy, the characteristic finding which we see is a Swiss cheese appearance. So Swiss cheese appearance of erythroblasts on electron microscopy. So Swiss cheese appearance as in there is going to be multiple sieve-like ... kind of an appearance. So Swiss cheese appearance of erythroblasts is seen in type 1 CDA. So a type 2 CDA is going to be the most common CDA, and it is also given the name of HEMPAS. So HEMPAS, actually it is because it is also going to give a positive reaction like that of a PNH. So because of that, it is going to it is given this name. So you don't have to remember this again. Hereditary erythroid multinuclearity with positive acid serum lysis test. Okay. So this is also called as HEMPAS, and the characteristic morphology here is going to be multinucleate and binucleate erythroid precursors will be there. So both multinucleate and binucleate precursors are going to be there. So this is the classical thing, multinuclearity. And on electron microscopy, if you see, there is going to be double cytoplasmic membrane. So cytoplasmic membrane, double cytoplasmic membrane is a characteristic feature of type 2 CDA on electron microscopy. So under type 3 CDA, which is an autosomal dominant condition, here it is going to have multinucleate gigantoblasts, right? Multinuclearity can be seen both in type 2 and type 3, but in type 3, it is going to be gigantoblasts, very big cells of erythroblast is going to be there. So these three things are can be direct one-liners here again. So the next one on the bone marrow failure is going to be aplastic anemia. So even though the name comes as anemia, it is going to be a pancytopenic kind of a picture. So all the lineages precursors are going to be affected because here the stem cell is going to be affected. So entire stem cell is going to be, the hematopoietic stem cell is going to be affected. So all the lineages are going to be affected, resulting in pancytopenic kind of a picture. So when pancytopenia is there, it's going to result in anemia related complications, then infections, then bleeding, right? And the most important thing about aplastic anemia is there is going to be no splenomegaly. There is no splenomegaly. And if you see the bone marrow is also going to be hypocellular because usually in some kind of pancytopenia, the bone marrow is trying to compensate for it and there will be hypercellularity, right? But this is one type of thing in the condition in which there is going to be a pancytopenic picture. Along with that, there is going to be a hypocellular bone marrow because stem cell itself is defective. So where will it produce the cells, right? So the stem cells defect is going to be there. And already while discussing PNH, I discussed PNH, aplastic anemia, MDS and AML are all related. So when this aplastic anemia being a stem cell defect, it acquires certain mutations. It can turn into either a MDS or a acute myeloid leukemia also. So the causes for this aplastic anemia can either be inherited causes or acquired causes. Under inherited causes, the most important one is the Fanconi's anemia. So Fanconi's anemia, it is an autosomal recessive condition, which is the defect is there in the FANC genes. So FANC genes are involved in the DNA repair. So what type of DNA repair? Homologous recombination. So under homologous recombination, we had Bloom syndrome, Fanconi's anemia and ataxia-telangiectasia, right? So Fanconi's anemia can result in this kind of aplastic anemia. This patients usually have a short stature and multiple congenital abnormalities along with this aplastic anemia. So under acquired causes of aplastic anemia, here viral infections are the most common cause. Again, parvovirus, B19 infection. When certain toxins and chemicals, then chemotherapeutic drugs like alkylating agents, chloramphenicol, benzene. So all of this can again cause decrease in the production of this stem cells. So aplastic anemia can be there. And finally, it can also occur as an idiopathic cause. If you look at the bone marrow biopsy of this aplastic anemia, here the cellularity is going to be quite decreased and it is mostly composed of fat cells only. Okay, so if it is a child, suppose a 10-year-old child, you will expect a cellularity of 100 minus 10 equal to 90. So 90% cellularity you will expect. But if the child is having aplastic anemia, it is going to be filled up with this kind of fat morphology. So these are the bony trabeculae here, these pink structures. So these cells, if you see here in these clusters, right, these are all the bone marrow cells. So normally in a child, it must say occupying the entire thing. But here it is all replaced by these fat cells. Only a small focus of bone marrow hematopoietic cells are seen. So this is the classical image of aplastic anemia. And for treatment, you cannot do anything since the stem cells itself is being affected. You just have to do a bone marrow transplant, no other. So now we had seen about all the types of anemia also.